Hello everyone, welcome to this video where we will be discussing the dermatology recall questions asked in the FMGE exam conducted very recently on 20th Jan 2023. With immense happiness, I can tell you that all the questions that have been asked in the paper were discussed through various discussions and interactions with the students. If you watch the regular videos or the rapid revision or the previous year question paper discussion, all across these have been discussed, and there is not a single question which I can say is out of what we have discussed. On the other hand, the questions are either exact same repeat of what has been asked or they are the same topic. So this actually tells you how important it is to revise the previous year's papers and be thorough with the content that is taught in the class. Now, some subjects I've got to know were difficult, but I'm sure the 100% marks that you get in dermatology will help you reach where you aspire to. Now, since this is a recall session, some questions may not be exactly similar to what has been asked in the exam. If you find any discrepancy, you can put it down in the comments. That will help the other students who are watching the video. And if they are correct, then very good. So for all the students here, let's start the discussion. A farmer presents with a history of penetrating trauma and a growth. What is the diagnosis? So the text here gives you three hints: a farmer with a penetrating trauma and a growth. So whenever there is a question with a farmer and a penetrating trauma, think of subcutaneous mycosis, because mostly in farmers the penetrating trauma is with plant and soil matter, which are rich with the fungi. So whenever such a scenario is given, the subcutaneous mycosis should be on the top of your mind. Now let us look at what the image is giving us. It says that the lesion is on the foot, again the most common site for a penetrating trauma and thus the lesion. And the lesion here is composed of a cauliflower-like growth. So there are multiple nodules and there is a cauliflower-like growth. The surface is rough or verrucous. Now, what is the diagnosis? Sporotrichosis, chromoblastomycosis, mycetoma, or a wart? Now, sporotrichosis, I'm sure all of you know how it looks like. It will look like multiple nodules in a linear pattern, a lymphoid distribution. So this is not how sporotrichosis looks. Mycetoma will be presenting as a swelling of a foot with discharging granules. Now you have to see between chromoblastomycosis and a wart. Now wart is also something that will present as papules and plaques with a rough verrucous surface. Yes, that's what a viral wart is. That's what its name says, a rough verrucous surface. Chromoblastomycosis, on the other hand, is a mycosis which will present with exactly the similar picture that is given in the question. It will be a cauliflower-like growth with a rough verrucous surface. So what is the answer here? The description in the text tells you it's a subcutaneous mycosis. The picture also gives you the image of chromoblastomycosis. So the correct answer to this question is chromoblastomycosis. Now, if I tell you to see the previous year's papers, almost 6-7 papers if you see, out of that 4 to 5 papers have a question on subcutaneous mycosis. This is now the most important topic for the FMGE exam, and the three important subcutaneous mycosis, chromo, sporo and mycetoma, are so important that you cannot not know them. I'm discussing all of these here. Please be very thorough with this topic because no other topic is as repeated as these. Now, chromoblastomycosis, the word chromo here tells you that this disease is caused by pigmented fungi. The two names that you can remember are Fonseca and Phyllophora. Now, how does it present? It presents with this typical growth here, which I just described as a cauliflower-like growth with a rough verrucous surface, which is why this disease is also called as verrucous dermatitis. And there is a finding here which is very important. In fact, it has been asked twice in the INI-CT exam also. So this finding here is very important. You see the yeast in the biopsy. The yeast here have an equatorial budding. So because of this equatorial budding, this kind of a picture comes in. So you see these copper colored structures. These copper colored structures here are called as copper penny bodies or medulla bodies or the sclerotic bodies. So the image of chromoblastomycosis as well as these copper penny bodies is very, very, very important. Next we come to sporotrichosis. It is caused by this fungi which is a dimorphic fungus, Sporothrix schenki. Again, a penetrating trauma with rose thorn forms a very important way of spread, which is why it is also called as rose gardener's disease. The inoculation might have happened somewhere here, so you get a nodulo-ulcerative lesion here and the infection spreads proximally in a linear pattern because it spreads along the lymphatics. So the distribution is a lymphoid pattern through ascending lymphangitis. I'm telling you the infection spreads proximally. So this is called as ascending lymphangitis. And you get these multiple nodulo-ulcerative lesions on the foot. Very, very, very important to know sporotrichosis. The name of the fungus, that it's a dimorphic fungus. Now, when you look at the histopath, you get the structure which is called as the asteroid body. You can see that the shape is like a star. So asteroid body is what you see in the histopath, and the shape of the yeast here is cigar. So you see these cigar shaped yeast. So all these findings, be very, very thorough: cigar shaped yeast and asteroid bodies. Treatment with itraconazole, and one more thing I want you to remember is the use of potassium iodide. So potassium iodide is used in the treatment and so is itraconazole. Next we have mycetoma. Mycetoma again spreads by penetration trauma in the farmer on the foot. But the clinical findings are different. It presents with a triad where you have a painless swelling. That swelling has sinuses which have discharge containing granules. So this is the triad. Even this has been asked in the exam. So what you have is a mass which is painless with sinuses with granules. That is what tells you that the patient is suffering from mycetoma. When it is caused by a fungus, it is called as mycetoma, and when it is caused by a bacteria, it is actinomycetoma. The most common organism causing 70% of the disease is Madurella mycetomatus. What do you see on the foot? You see that there is this swelling. Then it has multiple sinuses which are throwing out some discharge. On examination, you see these blackish granules. So this is how classically a mycetoma presents. When you do a gram stain of these granules, you see gram-negative fungi, and on radiology, an important sign is dot in circle sign. Treatment would be a surgical debridement with antifungals. Mostly we get itraconazole. So that is the treatment for mycetoma. Remember, the most common organism causing it is Madurella mycetomatus. And lastly, showing you an image of the wart also so that you know what is caused by human papilloma virus. And these common warts are actually caused by HPV type 2 and 4. When you look at the wart, it will be small papules. Some may be bigger plaques with a rough verrucous surface, but these will be mostly flat lesions. You know, wherever you see these lesions, these will be flat, not as raised to form a cauliflower-like growth. And you'll have a smaller history. They can be present, smaller means a shorter history. They may be present anywhere on the body, and a penetrating trauma is not necessary to cause them. So this is how you differentiate chromo from a wart. Moving to the next question. Here, a 30-year-old truck driver presents with history of multiple sex partners and skin lesions as shown below. what is the diagnosis? So the question here gives us a truck driver. Truck driver are high risk group. Now this patient also has multiple sex partners. So there is a very high risk of a STI being present in the patient and STI being asked in the question also. And what you have is skin lesions. What is the image showing? Image is showing hand with multiple coppery brown macules. So the image here is showing us multiple coppery brown macules. Now, where do you see coppery brown macules in a STI? You see them in secondary syphilis. This is an easy one here. I hope all of you have got it correct. So these coppery brown macules are seen in secondary syphilis. Let us look at the other options. Hand, foot and mouth disease would show us vesicles on hand, foot and mouth. Then it happens in children, not as an STI, and it is caused most commonly by this virus, which is Coxsackie A16. On its own, hand, foot, mouth is a very important question. Again, it has been asked at least twice in the last 2 years. So remember, it is caused by Coxsackie A16, happens in children with painful vesicles on the hand, foot and the mouth. Scabies would be in an adult, okay. Skin lesions on palms and soles are not seen in scabies. So in adult scabies, palms and soles are not involved. In infantile scabies, you see vesiculopustular lesions on the palms and soles. And what you would see on the hand is actually in the finger webs, you would see papules. So had it been an adult, then the lesions would have been in the finger webs, not on the palms and soles. So we rule out scabies, and psoriasis again would show red scaly lesions with silvery white scaling. There would be no significance of sex history being given in the question. So psoriasis is also not the answer here. So the correct answer to question 2 is option B, that is secondary syphilis. Just doing a brief discussion of syphilis here. Syphilis, when it initially comes to the skin, it presents as a primary syphilis. So the first manifestation here is primary syphilis, which is caused by Treponema pallidum with an incubation period of 9 to 90 days. So when the organism first comes on the skin, it causes primary syphilis, which causes or which presents as an ulcer. This ulcer here, as you see in the picture, is a well-defined round to ovoid ulcer. So it's number 1, well-defined. Then number 2, it has a clean surface. When you look at it, it looks moist, oozy, because there's a lot of serum coming out of it. On palpation, most importantly, it's a painless ulcer and it is indurated. So it's a painless indurated ulcer, also called as hard chancre or Hunterian chancre. So primary syphilis is also called as hard chancre or Hunterian chancre and typically presents as a painless, indurated, well-defined ulcer. The next investigation that you do in this is dark ground microscopy, where you see these spiral structures, which are these spirochetes. Their typical motility is corkscrew motility. On its own, every word on this slide is a question that can be asked from syphilis. So the image here becomes very important, both these images, the ulcer as well as the dark ground microscopy, which you should know. If the patient takes treatment, good enough. If the patient doesn't take treatment, now the bacteria are going to spread into the body. So this is the ulcer. From the ulcer, it goes to the lymph node. What are the kind of lymph nodes that you see in primary syphilis? Shorty, painless lymphadenopathy. Now, at this stage, if the patient takes treatment, good. If not, from these lymph nodes, the bacteria is going to spread all over the body and it will cause manifestations in the skin, in the mucosa, in the hair, as well as all over the organs. So secondary syphilis involves almost the entire body and it can present with multiple symptoms. So it is also called as a great imitator. Now, what do you see on the skin importantly are these lesions on the palms and soles, which are the coppery brown macules as shown in the image as well. So there will be a rash on the body and there will be these coppery brown lesions on the palms and the soles. Now rash on the body can be any morphology except vesiculobullous. Vesiculobullous lesions are not seen in secondary syphilis. So a rash on the body with coppery brown lesions on the palms and soles, you have to start thinking of secondary syphilis. Also, the patient has generalized painless lymph nodes all over the body, but characteristically there are epitrochlear lymph nodes involved. So here you have the epitrochlear lymph nodes. Coppery brown macules and epitrochlear lymph nodes, vesiculobullous lesions not seen. On the mucosa, a very important finding on the genitalia are these lesions, which are the condyloma lata. These are flat-topped moist oozy lesions that are seen in the groin. These are the most infectious lesions of secondary syphilis. Then on the hair, you see a patchy non-scarring alopecia that is called as moth-eaten alopecia. The most important investigation that you do in secondary syphilis is VDR, because that's positive in almost all patients. Now, treatment is a single dose of injection benzathine penicillin 2.4 million international units. So in primary syphilis as well as secondary syphilis, you give a single dose of penicillin, while in tertiary syphilis we give 3 doses 1 week apart. So remember, in secondary syphilis also there is a single dose of injection benzathine penicillin that is given. In some patients, on giving the treatment, there can be a sudden increase in the skin lesions, fever, joint pains. This is called as Jarisch-Herxheimer reaction. So just remember this word here, Jarisch-Herxheimer reaction. Happens on treatment of secondary syphilis. It is a type 3 hypersensitivity response. Especially important in pregnant patients, because there can be a risk of fetal complications when this thing happens. Now, coming to question number 3. A patient presents with multiple painful blisters on erythematous base along a dermatome as shown in the image. What is the diagnosis? Now, this question is giving you everything that you need to know in the text only. Even if the image was not given, I would be able to answer the question just based on what the text is telling you. Now, still let's look at the image. What you see? You see all these blisters on a red base, and they are present on the trunk along a dermatomal distribution. So when this kind of a clinical scenario is given to you, you know that I don't even need to read the options here, right? The diagnosis here is option B, that is herpes zoster, because that is what presents in this classic image along a dermatome. Let us still look at the other options now. Herpes simplex. Now, herpes simplex virus can cause 2 diseases which are important: orolabial herpes or genital herpes. Well, there's a long list that's caused by HSV1, but here I'm talking about orolabial and genital herpes. Again, the location and the dermatomal distribution would not be seen. Varicella would present with pleomorphic lesions all over the body and not along a dermatome. Molluscum contagiosum would be pearly white dome shaped papules. So even though herpes simplex would show grouped vesicles on a red base, but the location is different. It's not in a dermatome. Along a dermatome, it is only herpes zoster. Varicella caused by the same virus, but a different clinical picture. Molluscum contagiosum is white papules. So the correct answer to question number 3 here is option B, herpes zoster. Let us see how herpes zoster looks like. It's also called as shingles. Presents with unilateral dermatomal distribution. Very important, unilateral dermatomal distribution. The lesions are grouped painful vesicles on a red base. Most common site is the thoracic area. Where does the virus lie latent? In the dorsal nerve root ganglion. Okay, so all of these are important points about zoster. When you do an investigation on Zank smear, so in all these viral vesicular diseases, whether it be varicella, whether it be herpes simplex or herpes zoster, the investigation on the bedside is Zank smear. And what is the finding on Zank smear? These multinucleate giant cells. So the most important finding here are the multinucleate giant cells. And just remember this word here, also acantholytic cells are seen because of secondary acantholysis that happens here. So acantholytic cells is maybe somewhere in some corner of your mind. You can note this because it has been recently asked in the INI-CT exam, and multiple questions on multinucleate giant cells are anyway there. So the main finding on Zank are the MNGs. Treatment is with acyclovir. The dose is important, 800 mg 5 times a day for 7 days. In some patients, the pain takes a little time to go, but when it is persisting for more than 3 months, it is called as post-herpetic neuralgia. It's a type of allodynia. Okay, so this is about herpes zoster. Now the same virus, which is the varicella zoster virus, when it enters the skin for the first time, the primary disease is varicella. Then it goes and lies latent in the nerve root ganglia, as I just told you. And from there, when it comes out, it causes a secondary eruption, which is called as herpes zoster. So if you are asked the causative virus, it is the same for both varicella and herpes zoster. That is varicella zoster virus. In varicella, it causes a pleomorphic rash. This image has been asked in the exam. So varicella has a pleomorphic rash with a papule, vesicle, ulcer, scabbed lesion all present at the same time in the patient. When you look at the vesicle, it is present on a red base, which is called as dewdrops on a rose petal appearance. Okay. So varicella is not what was given in the question. Now coming to infections which are caused by the herpes simplex virus. Here I am talking about infection caused by HSV1, which is causing orolabial herpes. Again, a very important image based question that can be asked on its own. Here also you get grouped vesicles on red base. So that part is similar, but the lesions are present on the vermilion border of the lip, and they can also recur whenever there is fever or any other stressor on the body. So they are also called as fever sores or cold blisters. Very, very important is to know where they lie latent. Latency is in the trigeminal ganglion. So the infection comes from the trigeminal ganglion, causes an eruption, again becomes all right. Then whenever there is a stress, it will again travel and cause the eruption. So the virus lies latent in the trigeminal ganglion. Now coming to herpes genitalis, here also patient is presenting with grouped vesicles on a red base, but they are in the genital area, most commonly caused by HSV2. Sometimes the vesicles can rupture to form erosions. These erosions classically have polycyclic margins. So if ever you get a question on erosions with polycyclic margins, that is also talking about herpes. Again, the Zank findings are similar. That is the multinucleate giant cells. Treatment for all of this is acyclovir. But for oral and genital herpes, the dose is 400 mg 3 times a day for 7 days. So the dose here is 400 mg TDS for 7 days. The last option is molluscum contagiosum. I am actually discussing all these options here because one, you should know how to differentiate them from each other. Secondly, on their own, all these options are very, very important questions. So you should also know how molluscum looks like. It is caused by mollusky pox virus. So you should know it is caused by mollusky pox virus. Presents as pearly white dome-shaped papules with a central umbilication. You see that some lesions of molluscum here are present in a line. This particular thing is called as pseudocobnus. So molluscum is one of the causes of pseudocobnus phenomena. And the histopath is also an important image. Here you see that there is a lobular invagination of the epidermis, and you see multiple eosinophilic inclusion bodies here, which are called as Henderson-Peterson bodies. So the image of this histopath as well as the name of the inclusion bodies is very important. Henderson-Peterson bodies, eosinophilic intracytoplasmic inclusion bodies. This is the largest known double-stranded DNA virus. The inclusion bodies are the largest inclusion bodies in a virus. Okay, so this is about this question. Now moving to the next one. A patient presents with lesions covered with micaceous, silvery white scaling, nail pitting. What is the diagnosis? So the question on its own is giving us some hint in the form of a silvery white scaling and nail pitting, but let us see what the image is showing. So image is showing us multiple well-defined erythematous plaques. So that is what is the first look of the image. Well-defined erythematous plaques. Now when you look at the scaling, it is a micaceous silvery white scaling. So what you see here is a micaceous silvery white scaling. Now when this kind of an image with hint of the scaling as well as the nail pitting is given, the diagnosis is very clearly, again this is one question where I may not need to look at the options. Why? Because the silvery white scaling, the red plaques take us towards a diagnosis of option B, that is psoriasis. Okay, so the answer to this question here, question number 4, is option B, psoriasis. Lichen planus would give us purple papules, not what the image gives us. Pityriasis rosea would give us multiple papules in a Christmas tree, papules carrying plaques in a Christmas tree pattern, again not what the image tells us. And eczema would give us a red rash with mild scaling, but the scaling will not be as much, it will not be micaceous or silvery white, so that takes us again away from eczema. So the correct answer to question number 4 here is option B, that is psoriasis. Now this is how psoriasis looks like. Again you see in the image here a well-defined red plaque with silvery white scaling. Sometimes in the lesions on treatment you see this peripheral pallor, which is called as the ring of Warnoff. And again a very important image based question here is this. You see that it is a red plaque with silvery white scaling. In the center there is an erosion. In the erosion you see multiple pinpoint bleeding spots. This is called as the Auspitz sign. On Grittage test, that is scratching of a psoriatic lesion with a slide, you see this pinpoint bleeding, which is called as Auspitz sign. And another very important image based question from psoriasis is this, where you see multiple linear red scaly lesions here. This is what is called as the Kobnus phenomena, that is appearance of new lesions at sites of trauma, also called as isomorphic phenomena. So all these things, the typical lesion with silvery white scaling, the Warnoff ring, Auspitz sign, Kobnus phenomena, all of these are very important questions from psoriasis, and they have recently fallen a lot in love with psoriasis and lichen planus. In the last 4 papers, 3 papers have a question on these. Okay, so this is a very important topic again. All these images should be very clear to you. Now, the nail finding has also been mentioned in the paper here, because the most common finding in nail psoriasis is pitting, and the question told you that the patient has nail pitting. These are pinpoint depressions on the nail. This is the most common sign of nail psoriasis. The typical pitting in a psoriatic nail is CID. CID means coarse, irregular and deep pits. So coarse, irregular, deep pits is what you see in a psoriatic nail. Most specific finding is this, which is a translucent patch that you see here called as salmon patch or the oil drop sign. Okay, so most common is pitting, most specific is the oil drop sign. Now this image has also been given in your paper. This is the image where you see a lot of, this was given in the last to last paper, where you see a lot of scaling under the nail. This particular finding is called as subungual hyperkeratosis. Sub means under, ungual means nail. So there, and hyperkeratosis means scaling. So there is a lot of scaling under the nail. And when this scaling accumulates here, it is going to lift up the nail plate and separate it from the nail bed. This is called as onycholysis, is what you see here. A separated nail plate appears white. So that is the reason why you see it white from here till here. So these are all findings of nail psoriasis. Now some important types of psoriasis which can be asked in your exam and which have been asked. Very importantly, gutted psoriasis, where multiple small lesions of psoriasis appear after a streptococcal pharyngitis, most commonly seen in children. When you see this as an image, you see multiple red scaly papules all over the body. The drug of choice here is antibiotics because it's following a streptococcal infection. Then we have pustular psoriasis, also called as Wanzenbusch disease. Mostly the question is going to give you this clinical scenario where there is a sudden withdrawal of systemic steroids. So when a patient of psoriasis is taking some treatment from a local practitioner, suddenly stops the treatment, there are pustules all over the body. That is typically how a question describes pustular psoriasis. The drug of choice here is acitretin. So remember, the drug of choice for pustular psoriasis is acitretin. Now, pustular psoriasis of pregnancy is called as impetigo herpetiformis. Again, a very important question. Onsets in the last trimester of pregnancy, where you get multiple pustular lesions of psoriasis all over the body. The drug of choice here is systemic steroids. So this is the only indication for systemic steroids in psoriasis, that is impetigo herpetiformis. Now, histopath of psoriasis is also very important because in the December 21 exam, they asked questions on histopath of psoriasis. Now, what do you see here? December 21 as well as, the December 21 paper. So what do you see here? In the stratum corneum, you see parakeratosis, that is presence of nucleated keratinocytes in the stratum corneum. Then you see Munro's microabscesses, which is collection of neutrophils in the stratum corneum. Very, very important. This was the question that was asked. Munro's microabscesses are seen in psoriasis. Then there is hypogranulosis, that is reduced thickness of the stratum granulosum. Kogoch pustules in the stratum spinosum. These are again neutrophilic collections in the stratum spinosum. And the rete show a regular elongation. So these are all very, very important histopath findings of psoriasis which you should be aware of. Now, treatment, also questions have been asked, so you should know. In the topical therapy, important to remember vitamin D3 analogues and tazarotene. Generally, they don't ask you, but if at all they ask you, this is what they will ask. Vitamin D3 analogues and tazarotene. In the systemic therapy, methotrexate is the drug of choice for chronic plaque psoriasis as well as psoriasis with psoriatic arthritis. And this is what the question in that exam was. A patient who is a known case of psoriasis presents with psoriatic arthritis. What is the treatment of choice? So the treatment of choice for a patient suffering from both these diseases is methotrexate. Acitretin, I have already told you, is the treatment of choice for pustular psoriasis. Steroids for impetigo herpetiformis. Other than that, we can also give phototherapy, in which phototherapy of choice is narrowband UVB at a wavelength of 311 nanometer. Then you can also give psoralenes with UVA therapy. So psoriasis with UVA is called as PUVA therapy. So psoriasis, everything, the clinical features, the histopath, the treatment, all can be asked. Then there are some biologics, the anti-TNF alpha inhibitors like infliximab, etanercept, interleukin 17A inhibitors like secukinumab, isexekinumab, interleukin 12-23 inhibitors like ustekinumab, and phosphodiesterase 4 inhibitors like apremilast. Apremilast is an oral drug. So this is about the treatment of psoriasis. Then the option was eczema. So I've just shown you eczema here because it is also a red rash with scaling. But typically the scaling is not silvery white. It's very minimal fine scaling that you see here. Other than that, lesions can have vesicles and erosions. And since it is very itchy, patient will scratch it. So you may also see some scratch marks. So that is how eczema looks like. On histopath, you see spongiosis, and treatment is with steroids. Now, the last option was pityriasis rosea. Here again, you do see a red plaque with scaling, but the scaling typically is a peripheral collarette. So even though you see a red plaque with scaling, the typical scaling here is on the periphery in the form of a collar. So that's called as collarette scaling, and the lesions are present along the lines of cleavage in a Christmas tree pattern. This is what you see in pityriasis rosea. Again, not what was given in the question. Now coming to question number 5. A patient presents with itchy lesions as shown below. On examination, buccal cavity also has some findings. What is the diagnosis? Now there is some variance in the language of the question. One recall says that the patient presented with oral lesions as well as lesions on hand and feet as shown in the image. What is the diagnosis? The main hint in the question is that the lesions are itchy and there is also involvement of oral mucosa. When you look at the image, you see very beautiful color. What is this color? Purple. So you see these purple papules. So when you see purple papules plus oral cavity lesions, what is the diagnosis? I have just told you how, in which disease you see this. Psoriasis? No. Scabies would not. Scabies would give you itchy lesions, but they would not be purple in color and there will be no oral cavity involvement. What I've just shown you don't look like this. So what is the correct answer here? The correct answer here is lichen planus. The examiners have, I've told you, have become recently fond of these diseases. LP again has been asked at least 2 to 3 times in the last 3 years. So typical itchy purple papules plus oral mucosal involvement is what you see in lichen planus. I've put a brief discussion here. So the typical 5 P's of LP, purple polygonal planar pruritic papules, is what you saw in the image also. Then the lesions are classically itchy and they show a lacy reticulate network on the surface that is called as the Wickham's stria. Now I put another image here. Can you look at this image and see what is happening? There are multiple purple papules which are present in a line. So what is this? When lesions are present in a line like this, you have to think of Koebner's phenomena. So lichen planus is another cause of Koebner's phenomena. I showed you lesions of psoriasis. Now you have seen lichen planus. In fact, this is what we call as true Koebner's. And there are 3 diseases here, PLV, where P is for psoriasis, L is for LP. These 2 you have already seen. And V is for vitiligo. So these are causes of true Koebner's. On the mucosa, you see this violaceous patch with beautiful lacy white reticulate stria. Again, a very typical finding of oral mucosal LP are these lacy white reticulate stria, which are called as the Wickham's stria. There are 2 types of oral LP, reticular LP and erosive LP. Reticular LP is what you see in the image here. It is asymptomatic and generally an incidental finding when you examine the oral cavity. On the other hand, if in the lesion these erosions are present, Then it is called as erosive LP. Since there are erosions, patient will give history of burning sensation on eating hot spicy food. And also remember, erosive LP has a risk of developing SCC in the future. So this is what you see in the mucosa. Then histopath of LP has also been asked multiple times. In fact, in the December 21 exam, it was there. So what do you see on the histopath? It's a classic example of causing hypergranulosis, which in LP is wedge shaped. So you see this wedge shaped hypergranulosis. Then in the basal cell, there is vacuolization. The apoptotic keratinocytes are called as civet bodies. Then there is a band-like lymphocytic inflammation in the dermis. Rete ridges become pointed, which is called as sawtoothing of the rete. There is pigment incontinence. Together, these findings are called as interface dermatitis. So if you have to describe the histopath of LP in one word, the answer is interface dermatitis. Pathognomic finding is basal cell vacuolization. Another important named finding is civet bodies, then sawtoothing of the rete and band-like inflammation in the dermis. Very, very important points of histopath of lichen planus. Now, in the nail, a very important image here is this, where you see this wing-shaped fold of the proximal nail fold coming to the nail bed. This is called as pterygium. Pterygium is a pathognomic finding of nail lichen planus, causes permanent irreversible loss of nail. So an image of pterygium is very important question. In the hair, it causes lichen planopilaris, where you see a violaceous patch with scarring alopecia. So it is one of the causes of scarring alopecia. In the skin, purple papules which are itchy. In the mucosa, lacy stria. In the nail, pterygium. In the scalp, scarring alopecia. So all these four features of lichen planus on their own individually are important questions. Treatment is done with steroids. So treatment of choice for LP are steroids. Coming to question number 6. A patient presents with these following lesions to the OPD. What is the primary lesion of this disease? So what is it that the image is showing us? Image is showing us that the patient is presenting with multiple reddish nodulocystic lesions, some pustules, papules, and these smaller lesions. So what you see are these red nodulocystic lesions, and there are multiple other lesions present, so it's showing a pleomorphic picture. So this is what you see here. So when these reddish nodulocystic lesions, papules, pustules are all present on the face of a patient, the diagnosis here is acne. So the diagnosis is acne. Now, what is the primary lesion of acne? Papule, pustule, comedon, abscess. I'm sure all of you will say it's a very easy question here. So the difficult part is to identify the disease. Identify that it is acne and then tell me that the primary lesion is comedon. So the primary lesion of acne is comedon. Acne again is an important topic. In the previous exam, they asked you the bacteria that is involved in the pathogenesis of acne. So let us discuss acne in brief. This is a disorder of the pilosebaceous unit. There are 4 components to the pathogenesis: occlusion of the hair follicle, then increased sebum, increased bacteria, and inflammation. This is hyperkeratosis of the ostium is what causes comedon, and comedons are the primary lesions of acne. So comedons are special lesions, they are the primary lesions of acne. Then the bacteria that is involved here is Propionibacterium acnes. This question has recently been asked. Okay, so Propionibacterium acnes is involved in the pathogenesis of acne. Clinically, the patient can present with a predominantly comedonal acne, where you see these multiple blackheads and whiteheads on the forehead of the patient. The treatment of choice for comedonal acne is topical retinoids like tretinoin or adapalene. So treatment of choice for comedonal acne, this question has been asked with the image and you were asked the treatment of choice. So you should know that. And then again, very important here, they give you this image of nodulocystic acne. It is the most severe type of acne. The treatment of choice here is oral retinoids, isotretinoin at a dose of 1 mg per kg per day. The dose is important. Then a question on the total cumulative dose has also been asked, which is 120 to 150 mg per kg. So TCD of isotretinoin is 120 to 150 mg per kg. Some important adverse effects, isotretinoin. Most common side effect is cheilitis, that is dry chapped lips. But most important side effect asked twice in the last 3-4 exams. The most important side effect here is teratogenicity. So most important side effect of isotretinoin is teratogenicity, given always after doing a UPT, so negative UPT with double contraception. It is pregnancy category X. On stopping the drug, there has to be a gap of 1 month between stopping and planning of pregnancy. Now, another drug that has an important side effect is minocycline, where you see this typical blue-black pigmentation in the acne scars happen because of iron chelates in the skin. So these are two important drugs with risks that you should know. Question number 7. So a 3-month-old baby presents with a bright red birthmark as shown below. What is the diagnosis? So there is a baby here. In the image, it shows a red swelling, which is well defined. So there is a well defined red swelling and it is also raised, as we can see in the picture. Now, vascular lesions again are important, not asked as much in the last 2 years, but before that it was quite a common question. So when a baby comes to you with such a red raised swelling, which is not following any like specific distribution, it's not in the midline, it's not unilateral along the nerve, it is just a red swelling present at one point, no specific distribution. Now let us look at the options. Nevus simplex would be seen in a newborn. I'll just show you in the midline as just a mild erythema. Vascular malformation would not present like this. Again, it would be a different presentation. Port wine stain would be unilateral. It will be non-blanchable erythema that will be there. It won't really be such a localized swelling. Capillary hemangioma is what is the answer here. So the correct answer to question number 7 here is capillary hemangioma, that is infantile hemangioma, because that is what presents like this. I have put all these 3 here so that you can differentiate from each other. See, port wine stain will be present at birth. It will be unilateral, most commonly in the V1, V2 distribution of the trigeminal nerve, and it will be a non-blanchable erythema. So you see here unilateral along a specific distribution, and it is non-blanchable. So it's not like a raised small swelling. It's more flat at birth. And port wine stain is actually a capillary malformation, and it is persistent through the life, doesn't go away. Then we have salmon patch. Again, it's present at birth. Most commonly it has a midline distribution, either in the glabular area or the nape of neck, and it presents just as a macular erythema because it happens due to capillary ectasias. So there is just a dilation of the capillary, so it presents as a macular erythema. It's again not raised and it is blanchable. When it is present on the glabellar area, it's called as angel's kiss. When it is present on the nape of neck, it is stalk bite. Another name is nevus simplex, is what was written in the question. And it goes away on its own, doesn't require any treatment. Now, lastly, we have infantile hemangioma. Infantile hemangioma is not present at birth. So very, very importantly, it's not present at birth, and it comes in over the next few months, starts as a small swelling which then increases in size up to the age of 5 years. So this is what presents as this raised red swelling. It is actually a vascular tumor. So it's a vascular tumor, presents as this red raised swelling, increases in size for a few years, and then it resolves on its own by the age of 10. So there is no specific treatment required. It can self-resolve. But in some patients where it is growing very big or at functionally important sites showing ulceration, in those patients the treatment of choice is oral propranolol. Okay. So in those patients the treatment of choice is oral propranolol. So these are these three birthmarks here. Very, very important to be able to differentiate them from each other. Okay, so port wine stain and salmon patch are present at birth. Infantile hemangioma comes later. First of all, you see this, and then you differentiate between the port wine and the salmon patch. In this question, this hint was not given, so you actually had to identify from the morphology of the lesion. And the last question, this is like a combined question. You can call it from dermatology, you can call it from microbiology. But just a quick discussion here. Which of the following diseases happens by direct skin contact? So which of these diseases spreads via skin? Filariasis, schistosomiasis, dracunculiasis, or trypanosomiasis? So tell me, what is the answer here? Filariasis comes from a mosquito bite. Schistosomiasis, yes, here it penetrates from the skin and then travels to the mesenteric veins. Dracunculiasis comes from drinking contaminated water, which is full of the guinea worm larva, and trypanosomiasis comes from bite of the saysay fly. So that's African trypanosomiasis from the saysay fly. So which of these is happens by direct skin contact? Actually, direct skin contact is a very variable term. Not is actually spreading from skin to skin. It is spreading from the skin into the body. So the correct answer here is option B, that is schistosomiasis. With this, we finish our discussion. I hope it benefited all of you who have given the exam, in order to know whether you marked correct or not. And for those who are about to give the exam, knowing these previous year's questions becomes a very important part of your preparation. So please be very, very thorough with these ones. Thank you so much. All the best. And I hope for all of you who have given the exam, you get the result you want, you pass it, and then you move to the next phase of your life. Thank you so much.